Welcome to Doctor's Alert. Cardiac health is real matter of concern in this era, as the younger generation is more getting affected with heart attacks and other lifestyle diseases, which leads to chronic cardiac conditions. As we all know, we have to address these conditions in an appropriate way. Here is a team of doctors from Cardiology Department, Aster Hospital Mankhool, to give us the details about the precautionary measures, lifestyle changes, treatment protocols, and the treatment facilities available in Aster Hospitals. First of all, I would like to introduce our team of cardiology, Aster Hospital Mankhool, head of the department, Dr. Naveed Ahmed. Welcome, doctor.
Hello.
And Dr. Devabrata Dash. He's a cardiology consultant, intervention cardiology.
Hello.
And Dr. Sachin Upadhyaya, he's a specialist cardiology. Welcome, doctors, to the show.
Thank you.
Thank you.
Thank you very much.
Doctor, when going to the nowadays, we will be having a lot of cases in cardiology, and young people are more getting affected with that. So, would you like to give some information about that?
In Aster Hospital Mankhool, we cater mostly Southeast Asian population, expat population, mostly who comes from Southeast Asian countries like India, Pakistan, Bangladesh, Sri Lanka, and some of the patient also we get from Philippines. So predominantly, I would say more than 90% we get Southeast Asian population. We share a different gene compared to the Western population, wherein our gene put us an additional risk of coronary artery disease, that is the development of blockage. Compared to the Western population, we have a tendency of developing much earlier. In the West, this is still a disease of 50s, 60s, and 70s. However, in Southeast Asian population, this disease occurs at least a decade earlier. But the worst part, what we have seen being in Dubai in Aster Hospital is the same sort of population, what we were seeing back home. We see heart disease in the age of 40s and 50s, which is again a decade earlier. But surprisingly, we see much earlier compared to what we see in India, say in late 30s. That is more surprising. We are more concerned about this population because these are the population who have come all the way from their home country to live here, to earn and to support their family. When they suffer, it's not only one person who suffers, the entire family suffers. So I believe we have to focus more on younger generation to modify the risk factor to reduce. That's what we are seeing in the Aster Hospital here.
Okay, doctor. So, Dr. Sachin, would you like to add some information about how these youngsters has to take care of their health or to prevent such conditions?
Ideally, it's a lifestyle disease. So basically, it is all related to cholesterol and metabolic profile of a patient in terms of hypertension and sugar levels. So what I will suggest to the younger individuals is that live life in moderation, in the sense that they should not indulge in overeating the oils and fats and carbohydrates, and should be avoiding smoking. Get your BP checked every 6 months or at least every 1 year after the age of 30 to 35. In fact, it is not a bad idea to get it checked nowadays after 25, because in our hospital we have seen young MIs, young heart attacks even at the age of 26, 28, 20 and 30s. So get yourself checked, keep your hypertension, blood pressure under control, keep your sugar under control, keep your cholesterol under check, live life in moderation, avoid psychosocial stress. One thing I would like to point here is that InterHeart study, which was a very large study by Professor Salim Yusuf from Canada, McMaster University. He has pointed out, and it has been proved in that study, that lack of intake of fruits and vegetables also lead to increased risk of heart attack. That American College of Cardiology does not recommend any kind of gymming or any kind of exercise. What they recommend is that 30 minutes of walking every day, at least 5 days in a week, or 20 minutes of swimming at least 5 days in a week is sufficient.
Okay, thank you, doctor. So, Dr. Dash, can you tell interventional cardiology how it helps to recover that condition?
Interventional procedures, they involve non-surgical catheter based treatment, and these are less invasive, right?
Yeah.
So they help in treatment of angina, heart attack, carotid artery disease, peripheral vascular disease, renal artery disease, renal artery stenosis, and aortic disease. Even there is a paradigm shift is management of heart valve. So even valve deformity or leakage or stenosis can be managed with the replacement, that is percutaneous replacement, that is a new trend. And the commonest interventional approach is insertion of the catheter through the wrist or groin artery to the heart to open the blocked coronary artery, and that when the patient of heart attack comes in emergency, if you open it as early as possible, it saves lives. So that is most important thing, and these interventional procedures are important because they are less painful, they require only local anesthesia, the recovery is quicker, and they are more safe also because they do not undergo general anesthesia.
Okay, thank you, doctor. So, Dr. Naveed, when we concentrate to the young people and what they have to be aware of to avoid these conditions and all these health issues, what they have to be aware of?
Any person developing heart blockage, you cannot pinpoint what exactly resulted in blockage.
Okay.
It is the interplay of multiple factors like genetics, diabetes, hypertension, smoking, psychosocial stress, lack of physical activity, lack of fruits and vegetables in the diet. All this, interact. Maybe one factor predominate on other, but they do interact, and that results in ultimate blockage. So a person the person might come to us either for primary prevention, wherein he never had blockage, but he wants to understand the risk stratification, or the second set of population for secondary prevention. That means they've already suffered an event like heart attack, and now they come here how to reduce the subsequent heart attack. So when they come back, what we focus is we educate them. If they are smoker, strictly stop smoking. At some time they argue saying, I just smoke 1 cigarette a day. No amount of smoking is safe to anyone. They have to understand the earlier they quit, the better is the benefit, the longer is the benefit. That thing. Any diabetic individual or pre-diabetes, they have to, if the person is in pre-diabetic state, he has to do exercise, control it. But if, however, he is diabetic, along with the exercise, he should make sure he is adequately manage about his diabetes with the medication, and make sure his glycosylated hemoglobin, which is done every 3 months to assess, is well under control as per the guideline. Third is lipidemia, like high lipid cholesterol. That is very commonly associated with high degree blockages in the arteries.
Okay.
So guidelines have come out with a different level in different individuals. Say for primary prevention, who never had, we have a different set of goal lines.
Okay.
Person who has already suffered has a different set of goals. Why I'm explaining this is because many a time patient comes to us say my cholesterol is normal. That cholesterol might be normal for primary prevention. A person who has already suffered an event, even the number, say the bad cholesterol, we call it as LDL, their bad cholesterol might be 110, but the person might have suffered a heart attack. So 110 is not normal to him.
Okay.
Okay, then we targeted it much lower, either 70 or 55, to reduce the recurrence of events which can happen in future. That they have to understand, the titration of medication.
Okay.
Then plenty of fruits and vegetables. Eating less of junk, because again, the subset of population who lives here, they live, though they are married, but the thing is, like, they come travel here all the way from the home countries, they live alone more like a bachelor life. So they feel they don't have any support who can help them with cooking. So since they don't have time, it's not like they don't want to cook. Unfortunately, they don't have time. So what they end up is a quick grab from any of the smaller restaurant, which we don't know what sort of oil they are using. It will be full of fat, full of animal fat.
Yes.
And that's how they eat a lot, less of fruits and vegetables, sleep less, smoke a lot, less of physical activity. All this put them to risk of development of blockage and heart attack. So when any person comes to us, either for primary prevention or secondary prevention, we try to educate them in every aspect. They have to change their lifestyle overall. More of exercise, we would say aerobic exercise, not kind of weightlifting and all. It's like cardio exercise. So diet modification, fruits and vegetables, stop smoking, control the diabetes and lipids and hypertension as per the guideline. All this, if the person inculcate in his day-to-day activity, the chances of him or her having heart attack is very, very less.
Okay, okay, doctor. Dr. Sachin, coming to the same direction, lifestyle diseases, all these lifestyle diseases, how it contribute to a cardiac condition?
The lifestyle diseases, as we are discussing over last couple of questions, the lifestyle of an individual determines how his blood pressure will be, how his sugar levels will be, and how his cholesterol level will be. Together they form a triad which, along with other factors like smoking and alcohol intake, together with these factors, they lead to the blockages in the arteries, which is the actual ultimate cause of an heart attack or an angina. So these are the factors which one has to keep in mind to control, as I mentioned in the earlier question also, to keep these factors like keep blood pressure, sugar, cholesterol under check, avoid smoking and avoid alcohol intake, keep eating fruits and vegetables, and at least walk every day 30 minutes. So if you avoid these factors, in that inter-heart study, I would like to mention you a very astonishing fact that if you avoid these factors, you reduce the risk of heart attack by 90%. So these factors may sound to be, we hear them again and again and we feel that, these are the factors that we keep hearing, but they have a very, very huge contributory role in causation of an heart attack. And if you keep these factors under check, you are reducing the risk of an heart attack by 90%. So that is huge.
We have to do a regular checkup for all this, and
Yes.
we have to keep it in a limit so that we can prevent the cardiac conditions.
Absolutely.
Okay. Dr. Dash, when coming to interventional cardiac care, what are the new developments in the field?
Yes, the interventional cardiology has expanded dramatically of late, and that help us treating complex anatomy and complex patients. So emerging tools like artificial intelligence and machine learning are proving to be superior, and they improve the outcome. Another thing is robots in the cath lab. They manipulate the catheter from the distance, and this has an appeal when the procedure is long and complex. Then innovation in stent technology, like stent with thinner strut, improve the outcome. There is a bioobservable stent that is called dissolving. It dissolves over the period and then leaves the artery normal without any metal. This is development, and this will take a long way in the field of interventional cardiologist. Earlier, many complex disease such as left main, chronic total occlusion, and arteries with calcium, we used to refer to surgeon, and more those cases are being tackled with by an interventional cardiologist these days. And the imaging modalities such as intravascular ultrasound plays a key role in optimizing the stenting technique, and that is likely to improve the outcome. And in case of valve therapy, this is a new field. Like earlier, valve diseases used to be treated by open heart surgery, but nowadays through skin giving a nick, we introduce the valve and replace it. So transcatheter aortic valve replacement, transcatheter mitral valve repairs and replacement, transcatheter tricuspid valve repair and replacement are the new modalities nowadays.
So, doctor, when we talk about these cardiac conditions, when a person should start monitoring his uh, health or his measurements like blood test and all?
Even to say screening.
Yeah.
So the guideline, both American and European guideline address mostly the population who are in the West. Again, since the coronary artery disease is considered to be the disease of old in the West, the guideline says for them it is 40 years and above. However, this doesn't hold good, and we do not have any standard guideline which recommend for Southeast Asian population. Based on our experience, based on our colleagues' experience, what generally is recommended, especially a person who has a strong family history, like father, mother, uncles, maternal, paternal, or brother, sister, anyone suffered a heart attack, we consider them to be at higher risk because it might run in family. So they are the individual which has to be identified, should be screened right from, I would say, as early as 20 years for cholesterol, because cholesterol is one of the common factor which high cholesterol runs in families. So if it is identified the earlier, the better. Identify it earlier, treat it, modify it, and thereby reduce the risk, cumulative risk over a period of years. If there are no standard or risk factors like non-diabetic, non-hypertension, no family history, is a good active individual, yeah, the lipid, depending, since we are from Southeast Asian, we would recommend 25 to 30 is the earlier time where they have to screen for diabetes, lipid, and other risk factors. And yeah, though there are no standard guidelines for Southeast Asian population, the consensus what mostly say is with the strong family history, with other additional risk factor like diabetes, it should be done as early as from 20, at least a lipid profile, like sugar and other screening. And in case if no additional risk factors, 25 to 30 is the time what we are recommending.
So, Dr. Dash, while coming to Aster Hospitals, what are the facilities and developmental changes that happening in Aster group of hospitals?
Yeah, the Aster Hospital is well equipped to deal with coronary angiography, angioplasty and stenting, and for leg artery and artery of the neck, carotid angioplasty and peripheral angioplasty. Then follows stenting of the aorta, that also we are doing and the facility is there. Then imaging technology such as intravascular ultrasound, diagnostic modality such as FFR. Nowadays we are calculating microvascular resistance, that is a new modality and it is present in Aster Hospital. So this is quite important to know the exact cause of pain when the patient doesn't have significant blockage in the coronary artery, but still he continues to have pain. So we need to know why the chest pain is coming. So in order to do that, we calculate IMR, CFR, and that modality, that machine is with us. Then a process to deal with calcium loaded artery, we have newer super high pressure balloons. Then atherectomy devices like orbital atherectomy. So it drills the calcium and creates a passage for stent deployment. Then we have modality for valve therapy. So we can do TAVI here. Our lab is fully equipped for that. And for leaking mitral valve, mitral clip can be performed.
Okay.
And also ICD, pacemaker, and other abdominal arteries stenting can be done in our facility.
Okay, thank you.
And if I may add, Dr. Naveed, I think that Dr. Dash was mentioning about the IMR and CFR.
Yeah.
That is the machine that is not available across in
most
other
of the
part
hospitals
of
in
the
UAE, even
UAE.
including
That
India,
can be a
We are the
specialty
first
pharmacy.
to
this is a
start that.
recent thing which has come up, recent technology, still not available right now in India. Even in UAE, it is available in very few hospitals, and Aster, we have an opportunity. Aster has that facility. It's a small subset of population where we do an angiogram, we do not find any significant. Say, significant blockage is anything more than 70% narrowing in the artery. Less than 70% narrowing, we call it as, though there is blockage, it is not significant. So we say, well, even the guidelines say more than 70%, there is a chance patient might experience angina. So angina is when the patient walks, climbs stairs, rush, he'll develop kind of heaviness in the chest, tightness in the chest, kind of soreness in the chest. This is typical angina. So surprisingly, we have seen good number of patients where either their angio is normal or there is minor 20-30% block, but whenever they walk, when they climb stairs, they have that angina. So that's a big question mark for all of us. Is it related to heart or is it something muscular or bone related? Because say if it is related to heart, the person has to go on medicine related to heart for lifetime. And if it is not related to heart, unnecessary, some medication, it's a bunch of medicine. One cannot have it for lifetime if it is not required. So with this modality, which is very recent and one of the hospital is Aster which has it, we are able to clearly identify whether the person has angina or not and whether he needs to be continued on this medicine for lifetime or not. So this is where our Aster is going ahead of many other hospital in terms of offering the most recent way of evaluation and management in patient's care related to heart. We also started recent like coronary CT, so we can go CT angiogram here, like especially say younger, especially in females. So younger females have coming with the chest pain and they undergo treadmill, Treadmill, one cannot conclude whether it is positive or negative. Still, one cannot be convinced saying you do not have any heart issue. So that is the time where invasive, because every invasive angiogram comes with the risk. Though the risk is very small, it comes with the risk. And if the person, like younger female, where the probability, we calculate the probability of having heart disease is low to intermediate, that is like, say, no risk factors, sometimes pain, sometimes no pain, treadmill is borderline positive. Those are the individuals who can be subjected for CT, and if CT is normal, nothing else is required. So in Aster we have it. And the other recent development, we also have cardiac MRI. Again, very few hospital in UAE has this cardiac MRI, wherein it helps both for us as well as our surgery colleagues to understand, say, if that part of the heart is completely damaged, whether our stenting or bypass will help or not. Because, say, bypass comes with a major risk. Risk is worth taking if the benefit is big. If, say the artery which is blocked, the territory supplied by the artery, the part of the heart is already dead, damaged, there's no point of fixing it. So how do we understand? Because MRI helps us in understanding if there is any part of the heart is viable, that is, if there is any life in that part of the heart, still not damaged completely, it is worthwhile going ahead and fix it either with bypass or angioplasty. If it is completely damaged, there's no point. Putting the patient's risk for no benefit doesn't make sense. So in Aster, that's how we have progressed. So now we can offer much comprehensive care. A person coming here, we make sure they get the guideline based treatment and to the best what we can give to them.
Dr. Sachin, I have seen so many people with chest pain. I have seen even my colleagues, they are having chest pain, and simply chest pain. What are the things we have to do? Or we have to rush them to the hospital, or what will be your approach to that condition?
Yeah, it's a good question, because chest pain is something which can happen because of the heart and because of the simple reasons like musculoskeletal cause and acidity and gas. These are the usual causes of the chest pain, right? So one must recognize what kind of chest pain needs attention. As far as I would like to recommend that any chest pain of an individual which is persisting for more than 20 minutes, and if the patient is having this kind of chest pain which he says he has never experienced before, like acidity and gas, everybody knows how it occurs in an individual. If he says that it is a similar kind of pain that he experiences for last 10 years, then probably that chest pain is not heart related. But if he feels that that chest pain is something newer kind of chest pain, especially if it is radiating to the back, radiating to the arms, or is associated with symptoms of sweating or breathlessness, these are the chest pain which immediately needs attention, and the patient should go to the nearest facility for an ECG. We do an ECG. If ECG shows clear-cut heart attack, there is a sign called as ST elevation in an ECG. So we know that it is a clear-cut heart attack, and then we refer the patient to the nearest hospital where the cath lab facility of an angiography and angioplasty is available, and angiography angioplasty is done straight away. But in cases where ECG doesn't show, sometimes ECG doesn't show any changes which may suggest heart attack, then there is a test called as troponin, T or I, as available in the clinics or in the hospital. It should be done, and if it shows elevation beyond a certain limit which suggests heart attack, then we make a diagnosis of heart attack. That patient also needs an angiography and angioplasty as soon as possible. Sometimes this troponin, we see it very common, that they have done it in a clinic, but the results are borderline. So these borderline cases need to repeat a troponin after 2 hours, and if we see a rising trend, or if we see that the point has gone beyond a cutoff limit of an heart attack, then these individuals are also labeled as an heart attack, and then they are referred to the hospital with a cath lab facility, and angiography angioplasty is done. I would like to recommend that the chest pain should not be ignored, and any chest pain which is occurring for the first time in an atypical way associated with sweating or breathlessness, or sometimes individuals, they come and say that they feel chest pain when they walk. So that is a very critical and a clear-cut sign of an probable cause of an angina. It may not be a heart attack. Whether it is a heart attack or not, it will be done. It will be diagnosed by doing an ECG and a troponin. So any chest pain, as I mentioned before, should be brought to the attention of a clinician, and these are the steps that we follow to diagnose if it is a heart attack or not, and then we treat accordingly.
being the experts in the field, what are the messages you can give to our viewers?
Take-home messages,
To
yeah.
take-home messages you can give to our viewers.
I would like to mention that age-old wisdom of prevention better than cure is strictly to be followed. Prevention is much cheaper as compared to the cost of the treatment, not in the terms of money alone, but in terms of the time and the number of work hours wasted, besides causing psychosocial stress and agony to the individual. So one must follow the preventive aspects of controlling hypertension, diabetes, lipids, as I mentioned earlier. Maintain a strict no to a smoking, avoid alcohol, and at least walk half an hour every day. Avoid red meat, avoid oily food, avoid fried and fatty food as much as realistically possible, and try to inculcate to eat more and more fruit and vegetables and adopt a healthy lifestyle to avoid the risk of a heart attack.
So as rightly told, Dr. Sachin told, prevention is better than cure, no doubt in that. The primary focus should always be on the preventive part. However, once the person lands up with a heart attack to us, now what we should focus is, heart attack is every minute, major heart attack is damage to the heart muscle die. So the more we delay, the more is the damage to the heart, because heart damage is permanent damage, they don't recover. So what we focus here is, we open up the blocked artery to establish the flow, to stop the process of heart attack and prevent further damage, and which will save life. This is how it goes. So the focus in case a person who suffered a major heart attack should be earlier opening of the block artery. Every minute the muscle is lost. So we need to hurry up. So the appeal to all the audience is, please do not miss heart attacks. Like Dr. Sachin had already explained. So how to identify a person suffering heart attack. Okay, the pain persisting more than 20 minutes, the same pain increasing. Mostly it is described as a pain, no one can pinpoint it, mostly it is retrosternal. The whole of the chest is sore. Many a time patient describe it as like some mountain has been kept on his chest. So which can radiate to the neck, back, arms. Do not delay. Seek the medical attention. Immediately they'll do an ECG. And if ECG shows ST elevation, that is a major heart attack we call. In layman's term, it's a major heart attack because that is a life-threatening event. The more we delay, there's high chance person might lose life. Immediately he'll be mobilized to cath lab. We have a world-class cath lab with us. Immediately the artery is recanalized. We call it as putting a stent or ballooning it, establishing the flow in the artery. Thereby the duration of ischemia, duration of occlusion can be reduced. That prevents more death of the heart muscle, and recovery will be much better. Then the quality of life will be normal. Similarly, in case of minor heart attack, where the ECG changes may not be very significant, where the troponin is high, minor heart attack doesn't mean the problem is minor, only the damage is minor. If it is also, if not treated, many a time patients say it's a minor heart attack, nothing will happen. It has been seen minor heart attacks are precursor of major heart attack. Any point of time, this minor heart attack, if left untreated, they may go for major heart attack, can take life. So it is better to identify right at the time of minor heart attack, do an angiogram. If we find any major blockage, fix it. You can prevent progression of this minor to major heart attack, thereby it saves life. So our focus here will be to reduce prevention is better than cure. Once they have the problem, to address it as early as possible to prevent further damage, and long-term benefits will be there.
Dr. Dash, would you add some point to this?
Yeah, once you confront with complex coronary artery disease, so you should not refrain from meeting us, because we are offering now in most of the cases, especially in younger individual, less invasive catheter based therapies for left main disease, chronic total occlusion, and arteries we having multiple blocks. And also we have protected angioplasty with the help of ECMO that will improve the survival rate of the patient in critical situation. Then image guidance is there for better outcome, and whenever surgery is required in urgent basis, surgery is also there, but our aim is to give the treatment without open heart. So this is the comment.
Thank you so much, doctors, for your valuable time and
Thank you.
knowledge. And
Thank you.
we are really privileged to have such an expert team with us. Thank you so much. With this, we are winding up this session, this episode of Dr. Salad. We'll see you in the next week. Bye.